Hello, and welcome to another episode of Cardiometabolic Beat, brought to you by the Cardiometabolic Health Congress. Today we have the pleasure of speaking with Dr. Javed Butler, Professor and Chair of the Department of Medicine at the University of Mississippi Medical Center in Jackson, Mississippi. Dr. Butler is a renowned expert in heart failure. He has been the principal investigator of several major heart failure clinical trials and has published more than 650 peer-reviewed publications. Since several exciting developments have happened in the management of heart failure recently, we thought of this as a perfect time to have a conversation with Dr. Butler about these developments and what they mean for the management of patients with heart failure now and going forward. Dr. Butler, thank you for joining us today.
Absolutely. Great to be with you.
Thank you. I'll start by asking, so several exciting trials with SGLT2 inhibitors in heart failure were concluded and published in the last couple of years. What are some of the key takeaways from these trials, and how have they changed the management of heart failure?
Yeah, there is such a plethora of data that has come out in the past couple of years or so that it's really exciting. So first, perhaps even a little bit more than a couple of years, we had all these trials in type 2 diabetes where these drugs were showing that irrespective whether you have atherosclerotic cardiovascular disease or not, you're preventing heart failure. So prevention of heart failure in patients with diabetes who are at high risk of developing heart failure is a pretty important message. But then we started doing clinical trials in patients with manifest or prevalent heart failure. And the beauty there was that we really started testing these drugs as cardiovascular risk modifying agents, not as anti-diabetic agents. So the patients that were included in these trials were irrespective whether you have diabetes or not. So then we had 2 positive trials in heart failure with reduced ejection fraction, almost identical primary endpoint benefit, about 25% relative risk reduction in cardiovascular mortality, heart failure hospitalization. So now we proved 2 things, actually 3 things. One is that in HFrEF, they improve outcomes. 2 is that irrespective of diabetes, no diabetes doesn't matter. These are truly cardiovascular risk modifying agent. And 3 is that baseline therapy really didn't matter, and whether you were on sort of high-tech baseline care and whether you were on ARNI or not on ARNI or MRA, you really got benefit from these drugs. So then the question is, what are some of the other patient populations? So HFpEF is a big question. So now we have data from EMPEROR Preserved showing almost the same benefit as we saw in EMPEROR Reduced. Again, all 3 endpoints for cardiovascular death, heart failure hospitalization, total heart failure hospitalization, and EGFR preservation was met. We are eagerly awaiting results from the dapagliflozin HFpEF study or delivered. That's going to come out. So then we kind of move up a little bit in the spectrum of sickness. So there was a sort of a little bit of a niche trial done called Soloist. So it was only in worsening heart failure, only diabetic patient, and it's actually not an SGLT2 alone, but an SGLT2/1 inhibitor. That trial ran into a problem with COVID. So it was stopped early, only about 1,000 or so patients rather than the originally intended 4,000 to 5,000 patients. But even in that smaller trial, there was these sort of huge benefits that were seen. And then the last trial that came out was Impulse in acute heart failure. Day 2, 3 of the hospitalization, these patients were started a short 90-day endpoint. They have a composite win ratio of mortality, morbidity, and quality of life, and that was significantly improved even in the short term in these acute heart failure patients. So these are sort of the big trials. Then there is a quality of life trial with canagliflozin CHIEF-HF presented, again positive. Another quality of life trial with dapagliflozin called Preserved in HFpEF presented, also positive. So as you can see, lots of data and pretty much across the spectrum of prevention, treatment, HFrEF, HFpEF, worsening heart failure, acute heart failure. So far, all of them have been positive.
Wow, okay. Thank you so much for all that insight. What do you recommend to your patients who come into you to prevent this, if it's even preventable at that point?
Yeah, so, what we are learning now, obviously there are data gaps, right? So, we don't know whether in non-diabetic high-risk patients will it prevent heart failure. We have no data for that. But at least in patient populations that we have the data, what we are, Let's put it this way. If you develop heart failure, your risks are really high. We're talking about 45, 50% 5-year mortality. So that means that we ought to be treating patients aggressively at both ends. So if you can do some things to prevent heart failure, start it then. But if you get somebody who has already have heart failure, just realize what a high risk they are on, what a high risk these patients have, and then treat them aggressively as soon as possible. So definitely with SGLT2 inhibitor, if you have diabetes, you should be given these drugs, type 2 diabetes, not type 1, to prevent heart failure. And if you have, at this point, HFrEF or HFpEF, in my opinion, you should be treated with SGLT2 inhibitors. Having said that, I don't want to get ahead of the guidelines. Guidelines only, American guidelines are awaited. European guidelines are only about HFrEF, and they will be updated as HFpEF data comes out.
Okay, that makes sense. What would be some symptoms that someone would experience if they were possibly having heart failure, in case someone doesn't know that at this point?
That is such an incredibly important question because we all get sort of excited about, clinical trial and statistics and data. But the biggest thing is that unfortunately, the diagnosis of heart failure is significantly delayed. The number one place, almost 80% of the heart failure is diagnosed in the emergency department. And the reason for that is not that first time you develop heart failure symptoms, you need to show up in the emergency room. It's because people have symptoms for days, months, weeks, years sometimes, but they're not diagnosed with heart failure because the symptoms are non-specific. So you have shortness of breath, tiredness, fatigue. And what ends up happening is that you go to a clinician and clinicians appropriately rule out things like anemia and thyroid dysfunction and, lung problems, asthma, COPD, etc. And then you kind of blame it on aging and obesity, not realizing that 6 months ago when you didn't have symptoms, you were sort of equally old and probably have the same weight. So there is a change and we need to evaluate. So in that list of differential diagnoses for these non-specific symptoms, we should really keep heart failure in mind as well and evaluate that. So no, nothing specific per se, but again, shortness of breath, tiredness, fatigue. You can have other esoteric symptoms, but I think these three will cover most.
Okay. Thank you for sharing that with us, because sometimes it seems to come out of nowhere and people don't know what to think. So that's very interesting. So what do we still have to learn about SGLT2 inhibitors in the prevention and management of heart failure? And also, what are some of the key areas we still need additional information on?
Yeah, so let me just quickly say what are the trials that are ongoing. So, we have a trial with dapagliflozin with HFpEF, so we'll learn a lot. There's a trial with dapagliflozin in acute heart failure, so we'll learn about that a lot as well. Chronic kidney disease and heart failure is a pretty tight link. So we now have 2 trials in chronic kidney disease, but they had significant albuminuria. But there's another trial going on called EMPA-Kidney that is looking at across the spectrum, including with much less albuminuria. So that's interesting. Then in terms of prevention, we have 2 trials going on in post-MI patients. So acute MI patients in the hospital with myocardial infarction, starting empagliflozin or dapagliflozin, 2 separate trials to see if risk of mortality or new onset heart failure can be prevented. So all of this is ongoing and we will learn more about it. The second part of your question, what would be good to know? Well, we talk about sort of metformin as something which in patients with prediabetes prevents the development or slows the chances of development of diabetes. But there are some data with SGLT2 inhibitors as well. So I think one good thing would be to see whether these drugs prevent diabetes or not and be given even more upstream, but we really don't have definitive data. And then in the same realm, non-diabetic high-risk patients, can you have cardiovascular outcomes improve? Now, non-diabetic CKD patients, we already have data from DAPA-CKD that you improve outcomes. But I'm talking about post-MI patients, we will have the data, but generally patients with multiple risk factors, but who don't have MI or CKD, whether we can give that. That will be a little bit of a far cry right now. But at least the prediabetes question is really important and probably should be answered.
What if a patient didn't have any symptoms at all or doesn't have any pre-existing conditions and it just comes out of nowhere? Is there anything that you'd recommend for that?
Well, so a couple of things. So first of all, remember that a lot of the heart failure goes along not only for a long time with non-specific symptoms. A lot of the patients have already actually developed cardiovascular dysfunction and are actually asymptomatic. So that's an academic problem. That's a scientific problem. But I think we should be working on screening for heart failure and population-based, natriuretic peptide testing and whatnot. So one aspect is that. But from the patient perspective, the biggest thing is that what ends up happening is that when patients start getting tired or fatigue or shortness of breath, forget about the clinicians, the doctors and the nurses. The patients themselves have a tendency to just sort of ignore those symptoms and say, you know what, I mean, they'll go away, or maybe I'm just getting old, or maybe I'm just, I've gained some weight. And what they do is that they lower their expectations from life. So, they used to go and, walk in the mall for 15 minutes, 5 times a week, and now they do only twice, or maybe, they just go to the, mailbox, or chores that they could do at home. Now they, ask their children or somebody else to help with, but they tend to just ignore that there may be something going on. Now, sometimes it is just weight loss, weight gain, but at least get it evaluated to just make sure that you're not missing something.
And what kind of test would you get that evaluated with specifically?
Yeah, so if you come to a cardiologist, I think you'll get an echocardiogram, but I think even in the primary care setting, just getting simple natriuretic peptide. Now, of course, there's a whole science between the sort of false positive, false negative, and we can discuss that. But the bottom line is that for most of the patients, natriuretic peptide testing is a really good screening method.
Okay, great to know. Also, in addition to SGLT2 inhibitors, there are other new and emerging agents that target different pathways in heart failure. What role do they play in treatment of heart failure?
Yeah, so it's a pretty rich field right now, and you mentioned other drugs, but also there's a ton of new devices that are being tested also. So I think it's going to be a pretty rich field for some time as this evidence accumulates. But in terms of the drugs, we have these 4 quadruple sort of foundational therapy. RNA, evidence-based beta blocker, evidence-based MRA, and evidence-based SGLT2 inhibitor. Then we have a drug called vericiguat, which is soluble guanylate cyclase stimulator, specifically tested in patients with worsening heart failure and improves outcomes. So if somebody's sort of failing standard therapy, that's a good option. There's another trial of IV iron replacement. Again, substantial improvement in outcomes as well. So let's not forget about iron deficiency in heart failure patients. There's another trial with myosin activator, omecamtiv mecarbil, that was done, and especially people with really low ejection fraction, there seems to be a significant improvement, even if in the overall trial population the results were modest. But that drug has not gone through the regulatory process and is not available right now. But at least vericiguat and IV iron will be 2 additional options on top of the standard therapy.
Wow, that is crazy. There's so many options here. Wow. I guess last but not least, we now have several options for the treatment of heart failure. And with the addition of some agents of the ones you mentioned, what is considered foundational therapy?
Yeah, so that will be 4 drugs covering 5 pathways, which is angiotensin receptor neprilysin inhibitor that covers 2 pathways, angiotensin 2 and neprilysin, beta blocker, MRA that covers aldosterone, and SGLT2 inhibitors. That's the foundational therapy, all the way up to sort of ejection fraction of 50%. Now, in true HFpEF or ejection fraction greater than 50%, definitely SGLT2 inhibitors. I would personally include MRA in that also, although there's some controversy, some trials going on, and perhaps up to 55% ARNIs as well.
Okay. Thank you. And how is this evidence translated to practice, and how should clinicians think about individualizing HF therapy to maximize the use of all these available therapeutic approaches?
Yeah, so obviously there are practical considerations here because it's getting a little bit complex. So I think any systematic approach towards it will be better rather than individually doing it, and people forget, and inertia, and we know that the community-based uptake is relatively poor. I also am very cognizant that we have a lot of non-generic drugs that cost a lot. But at least if we can do two things, people who have the coverage, make sure that they at least get it. And right now, triple therapy, forget about quadruple, even triple therapy is given to less than 30% of the patient. So we know that coverage is not an issue for 70% of the patient. There is more than coverage, which is a problem. So at least give it to patients who have coverage, have shared decision making, discuss with the patient related to cost and related to the potential benefit. And in some cases, you're just not going to be able to prescribe it. But at least if you can get the science right, remember that ACE inhibitors and beta blockers were not generic at one time, and in the hopefully moderate future, SGLT2 and ARNI will be generic as well. So at least just realize that these are the 4 drugs that we need to give to the patients, and then individually make the decision at that time.
Okay. Wow, thank you for all your expertise. It was a pleasure talking with you. Is there anything else you'd like to share?
I mean, the only thing that I would say is that we have this none of the other chronic diseases, like if you have somebody with a blood pressure of 180 systolic, or diabetic with a hemoglobin A1C of 11, or I don't know, dyslipidemia with LDL of 170, we will never leave these patients alone because they are doing okay. The whole purpose of medicine is to treat aggressively so that you can prevent from bad things happening. And everybody will treat these patients and not sort of ignore them just because they don't have any symptoms, because by definition, these diseases are asymptomatic. But for heart failure, we don't have that mindset. And it is so common to see that people are not on appropriate therapy. And when you ask the reason why, and the answer is because the patients are doing okay. So it sort of it doesn't make sense for us to actually deliberately wait for things to get worse and see if you can reverse it. And that doesn't always work out. So just treat the patient aggressively as early as you can.
Thank you so much, Dr. Butler, for your time and expertise.
My pleasure. Thank you so much.
And thanks to all of you for listening. If you have any questions or if you have any feedback on topics that you would like us to discuss in the future, we would love to hear from you. You can email us at info@cardiometabolichealth.org or through social media via Facebook at Cardiometabolic Health or via Twitter and Instagram at CMHC_CME. Thank you, and until next time, have a wonderful week.